All right, anaphylaxis. You had a learning activity on this, so you're all pretty up on this. You know it, or at least chunks of it. But I want to talk about this. I think Professor Hunsaker mostly addressed anaphylaxis in terms of you're the school nurse or the wife or the husband or the significant other, and they're having a symptom at the house. You give the EpiPen, right? We're going to talk a little bit about dealing with in the hospital setting when it moves into anaphylactic shock as well. So that's a slightly different agenda because it's just more holistic because it adds on to it. So you've probably talked already about it being a systemic allergic reaction in response to IgE. It's an allergy gone wild, right? Doesn't just get the little, oh, my nose is stuffy, but body goes dump, right? So meds, foods, insect stings, most common. So first case of anaphylaxis was recorded in 2600 BC in petroglyphs, hieroglyphics, experienced by a pharaoh who got bee sting. I have no idea what killed things had. We didn't call it anaphylaxis until 12, huh? Whoever carved it in stone. We don't know who that was. He didn't sign his name. He was some poor guy working for free, and he was probably a slave. Yeah. Egypt. By a pharaoh in hieroglyphics. Okay. IgE binds to FCER receptors on mast cells. Your big cells involved in anaphylaxis are your mast cells, followed up by your basophils and eosinophils. Eosinophils are typically our number one allergy guy. You know, when you got hay fever, it's eosinophils are going to be out. But the mast cells and basophils go crazy here, right? IgE often is for parasitic infections, too. So if you've got a tapeworm, your IgE is going to be out. I don't recommend it. All right, so the mast cells say, ooh, I love IgE. That's the globulin I like. Remember those, with your immune globulins, those G, A, M, D, and E, right? And mast cells love E. They're like, oh, I want to go stick to that. I love that, okay? Mast cells originate in the bone marrow, live in our connective tissue, which means mucous membrane linings on things, right? That's a place that they hang out. So the IgE, when it's active, and it says, ooh, antibody active, the mast cell sticks, and it says, activate, activate. I want you to granulate. That's what it's going to tell the mast cell to do. A granulating mast cell is what starts releasing all these chemicals, okay? And it's got all the stuff that makes us experience allergies. Histamine, you guys know all about antihistamines, right? Leukotrienes, cytokines, all kinds of stuff. Okay, so just pictures from, I think this picture's in your book too. Mast cell granulates. You know with allergies also are a sensitization process. Your first exposure to an antigen doesn't cause the allergy. Because your first exposure, your body goes, huh, that doesn't look quite right. I'm going to make an antibody against it. And it spends the next little while making that antibody, IgE, antibody. And then the next time you get exposed, it goes, ooh, we recognize we don't like this, and we're going to attack it fast, right? So it's subsequent exposures, second or third exposures, that we really have the bigger symptoms. That's when the allergies really hit us. So our B cells produce the antibody, IgE. The antibody is bound to the mast cell. And then our mast cell says, okay, I'm granulating. I'm going to do my thing. That's a granulating mast cell, a thing of beauty to behold. It just makes you feel horrible. All right, so what does it do? The symptoms of the contents of the mast cells, the bradykinin, the histamine, all that stuff, cause peripheral vasodilation. They cause your small capillaries and mid-sized arterioles to dilate. So things open up. So that causes edema, right? It opens up the spaces in the walls of the capillaries, and liquid fluid can leak out. So you get edema, angioedema, periorbital edema, tongue edema, bronchial airway edema. They also cause constriction of airway, bronchospasm. So airway manifestations during an anaphylactic response, right? Cardiac arrhythmias, that's always bad. Abnormal beats of the heart, never a good thing. Smooth muscle contractions, intestines, cramping. A lot of people with food allergies will get diarrhea, right? Even during an anaphylactic response, you can have a bowel episode. Hypotension from this, right? From this, and it's systemic. Now, you learn what are the sequelae is anaphylactic shock. You learn shock in terms of hemorrhagic shock and peri-op, probably. Somewhere in that world, you learned hemorrhagic shock last semester.
No.
Oh, cool. Okay. So you've had no shock experience before? This is your first shock exposure? Love it. That's critical care. Let me talk about that. Okay. So shock is when stuff doesn't perfuse. That's literally what it is. It's not perfusing. I don't know why we have the name shock. We do. So they're all represented by a dropping blood pressure. They're all represented, I can't say that. They're all represented by a dropping blood pressure. Period. I was going to give you some other symptoms, but depending on the kind of shock, those symptoms will change. There are various types of shock. There is hemorrhagic shock. I lose blood. Somebody sticks me with an ice pick a bunch, my heart perforates, it has a hole in my chest and it's gushing out, I get hemorrhagic shock. I'm an ice pick girl. All my injuries are generally originated with an ice pick. So now your patient's hemorrhaging, he lost blood. So what happens when you lose blood? Your blood pressure goes down, right? You have less fluids in your arterial space. Now your body says, ooh, I lost fluid, but I still need oxygen in my lungs and my brain and my kidneys and my heart, right? So I'm going to speed up my heart rate to take the lesser amount of blood and red cells and pump them around my body, right? I got to come around faster because I still have to have oxygen. So tachycardia happens, right? Dropping blood pressure, rapid pulse, right? It's compensatory. The body's going, I'm compensating for the blood loss. I'm going to speed up my heart rate. But if I continue to lose blood, my blood pressure is going to continue to drop. My heart rate's going to get faster and faster, but it only can do that for a while, right? At some point, our body's going to go, look, it's 180. I don't know what you want of me. I can't keep up. And you're going to have hypoxia because you can't keep up. You don't have enough oxygen on your cells. So in your brain, what happens when you don't get enough oxygen? Anxiety, confusion, restlessness, decreasing level of consciousness, all the way to coma and death. That's always bad. What happens to your kidneys?
Low output.
Low output. Your urine output drops. What's normal urine output? 30 mils an hour. Anything below that we're worried about. But if you continue to lose fluid, you're not going to make urine output. So kidneys are going to go, don't have oxygen. I'm getting an acute kidney failure episode from an ischemic episode, right? So in your heart has blood vessels on the surface of the heart that bring oxygen to the heart. It's not the heart in the chamber of the heart that feed it. So those little blood vessels on the surface of the heart don't get enough oxygen, and what's your symptom? Chest pain, ischemia. Starts with angina, but you can have a heart attack too, right? So you've got your brain, your heart, your lungs. You're breathing faster. You think your body's compensating. It's going to do tachypnea. But the lungs themselves need perfusion. And if they don't have that, at some point they're not going to be able to keep up either. So it's a spiral. We have to stop the spiral with hemorrhagic shock. We have to stop the bleeding and replace fluid, right? So we're going to start with IV fluids. If in the ideal world, we'd replace blood, right? That takes a little while. Have to be type and cross match. You may or may not be compatible. There's lots of side effects to that. So sometimes we give just fluids depending on how far you are. So that's hemorrhagic. Far and by wide, the most common shock you will deal with in the world of healthcare. Post-operative patients, trauma patients, lots of people have it. Burn patients, right? All those people could fit in that. And then there's the distributive shocks. Distributive shocks say, you never actually lost fluid from your body. In the hemorrhagic shock, I lost fluid. Distributive shock, I didn't actually lose fluid. But I had anaphylaxis that made all my arterioles dilate. So I have 3 liters or 4 liters of fluid, that it's now in this much space. So my blood pressure goes down, right? And my heart rate says, wait, my blood pressure is really low. I need perfusion. Speed up, right? So tachycardia, hypotension, right? If we don't stop, which one of these was I doing? Anaphylactic, right? Oh, there's 5 kinds of shocks, right? Okay, distribute. Let's do one of the distributors. Anaphylactic. If I don't stop my antigen antibody mast cells from dilating, I'm going to continue to dilate, and my hypotension is going to get worse and worse and worse, and I could die. So I have to stop the mast cell dump. I have to stop that to constrict my arterioles and bring my blood pressure up. That's treating the cause. I still, in transition to that, and while I'm stabilizing, I probably need fluids. Every patient in shock gets fluids because all of them are hypotensive. So I'm giving my patients some fluids if I'm inpatient. If I'm their next door neighbor with an EpiPen, I probably don't have an IV Ringer's lactate hanging, right? So I'm doing my EpiPen to stop the mast cell thing. But if I'm in the hospital and I'm a nurse, I can, yes, give you your epi. Yes, I'm going to treat that. But I'm going to start an IV and run some fluids, right? I'm going to put some oxygen on you because you've got this much volume, this much blood. I'm going to hyperoxygenate. I'm going to maximize the oxygen carrying capacity of every single stinking red cell I have. So they're all going, oh, I'm loaded up with oxygen. Let's carry it around, right? Because we still need our tissues to oxygenate. Make sense? Okay, that's anaphylaxis. Another distributor shock is septic shock. You do that in level 4. Septic shock is I have this big bad infection, most often a gram-negative bacteria, and it secretes an endotoxin that my body says, ooh, bad infection, I'm going to vasodilate. It's our immune system gone weird. So it doesn't just fight the infection, it causes massive vasodilation from the infection. So I still have my 3 to 5 liters of blood, and it's like anaphylaxis. It's in this much volume. So I need to do something to constrict my blood vessels, right? But it's not an allergic response. An EpiPen is not my treatment of choice with that, right? EpiPen isn't going to treat sepsis. No. So my treatment in that is tons and tons and tons of fluid, fill up the space while we fight the infection. So my first 3 things with sepsis are fluids, blood cultures, and appropriate antibiotics. Make sense? Mm-hmm. And then we're going to give norepinephrine to constrict their blood vessels. So you'll do that next semester. Not on this test. Anaphylaxis on this test. There's also neurogenic shock. Again, only one on this test, anaphylaxis. You're supposed to have like an introduction to shock last year, and if it didn't happen, I'm taking care of that. And it's so interesting, and I love this. Okay, so we're doing anaphylaxis on this test. It's the only one you have to know for me, okay? But I think it's good for you going into the hospital to recognize, wait, my patient has a low blood pressure and a rapid heart rate, and they are failing on me. Perhaps I need to do something, and it's not because I gave them an antibiotic. It's because they got it, it's not because of the bee sting. It's because of their infection, or it's because of their motor vehicle trauma, or it's because of their head injury, right? So the other kind of shock is neurogenic shock. There's one more. You can, not on this test, I'm just talking. You don't have to take notes. I just want you to absorb, right? Neurogenic shock. Neurogenic shock happens when we have injury to the brain and spinal cord. Because the brain says, ooh, let's put a little nervous system innervation on all those blood vessels and keep them constricted and dilating and constricting as they're supposed to. So now your patient gets conked over the head when they fell off their ladder, and they got a major head injury, and the brain goes, I forgot what I'm supposed to do for a while. And it says, okay, let's not constrict, let's dilate everything. So again, it's distributed. It's the same problem. Same amount of blood, this much space. Right? My problem is it's caused from the brain not doing its thing, right? So my treatment is going to be fluids, because treating the brain is going to take a little longer. Fluids, get them to constrict, maybe some epinephrine, norepinephrine to constrict. And then I'm going to have to treat their brain problem. I got to fix the swelling in the brain and the injury to the brain, right? So do you kind of see? But they all cause shock. They all cause that drop in blood pressure, hypoxemia of your tissues, right? I'm still going to get done in a timely manner, I promise. So anaphylaxis now, I have this antigen-antibody response. The mast cell dumps its contents that cause massive vasodilation and bronchospasm. So not only am I dilated and my blood pressure is dropping, my heart rate's picking up to compensate for that. It wants to carry maximum oxygen, but in my lungs it's going, constrict! And you can't get enough oxygen, right? So you're compounding the hypoxemia. Dropping blood pressure and massive hypoxemia can kill you. So this is highly lethal. We have to treat it fast, or my patient's not going to be alive in 10 minutes. All right. I guess I can move on. Has nothing to do. You know what? The more you hear it, you need that for. If I'm taking care of a post-operative patient and their blood pressure drops and they lost 2 liters of fluid in the surgery, what am I going to expect, right? All right. So this is just a graphic picture of mast cells granulating, the antibodies sticking, whatever. Another one. They all come from your books and things. I just, whichever one helps you figure it out. So what are the mediators that are involved? Those are chemicals from your body that influence this process. All of this stuff makes it worse. Okay? We have histamines, proteases, leukotrienes, prostaglandin D, cytokines. They're all products of inflammation that have to be blocked because they're going to cause vasodilation and leakage of fluids out of the main vascular space. Every one of those is going to help contribute to that. So, interleukin matures the B cells, released by the T cells, tells the T cells, the mast cells to do their things. They attract eosinophils, which is kind of fun, because the eosinophils are going to elevate with all allergies. All right, another granulating mast cell. Aren't they pretty? They're so pretty, but they're really dangerous. All right, so our histamine, we have different kinds of histamine. We have histamine that's going to affect the smooth muscle and the endothelium. We have histamine that's going to in the gastric mucosa. What's Tagamet?
Which one?
Tagamet. Cimetidine, the generic name. Tagamet, cimetidine. It is Dean. Okay, check it's an antihistamine. It's an anti-ulcer drug. It's a GERD drug. We give it for ulcerative, like for the gastric reflux, right? But it is an antihistamine. Zantac and Tagamet, cimetidine, Rantidine, are both antihistamines because they affect the gastric mucosa histamine that stops the gastric acids. And so, can it be helpful in allergies? Mildly. We want the one that's going to work on the airway for allergies, right? Because it's going to cleanse your airway, not your reflux. Just thinking. All right. So we're going to we got H1 receptors, H2 receptors, and H3 receptors in the brain. And that's when they pick up something, their job is counterbalance. We got a lot of histamine going on. I'm picking up a receptor here. Maybe it's time for me to shut it down so we don't go crazy with allergy, right? That's what should happen. With anaphylaxis, you go crazy with allergy. All right, so my cardiovascular effect, a decreased blood pressure, an increased heart rate, and edema as fluid leaks out into third spaces. So we have angioedema, periorbital edema, tongue, airways, everything's puffy and swelling. Respiratory bronchial constriction, GI, contractions and diarrhea of the smooth muscle, skin, hives. What are those? They're big like welts. They're elevated, and they're not always reddened. Sometimes they are, and they usually have urticaria. Urticaria. What's that? Itching and swelling. So, woo, that was fun. I itched my microphone right off my chest. It's not even, it is. It's on. Okay. All right. So, high swelling. So you can see the picture of the patient, right? Most common allergens out there, penicillin, sulfonamides, and tetracycline, cephalosporins. Those are all antibiotics. Do we ever give those in the hospital? Oh my gosh, yes. NSAIDs. A lot of people are allergic to ibuprofen. Insulin.
What?
Our own insulin we're not allergic to. But when we give insulin from the pharmaceutical companies, they're bovine, porcine, or human, but it's not my human. It's some other. They didn't make it for me, right? So there's a lot of antigens on there that people can be allergic to. Aspirin, eggs, nuts, milk products, shellfish, chocolate, strawberries, Iodine and iodine-based products, bee stings, wasp stings, snake bites, rabies, blood products. With blood, no, everything's dangerous. Blood products, the deal with anaphylaxis and that is the ABO and RH compatibility, right? So you have to match your blood type, match the antigens and the RH antigens on your blood to decrease the risk of anaphylaxis. Iodine-based products, do we have those in healthcare?
Yeah.
Oh my gosh, everywhere. Any shellfish allergy, we also watch the iodine products on. A lot of people are allergic to shellfish.
Is there a reason latex isn't on this list?
Most latex allergies start as cutaneous allergies and don't always become anaphylaxis. There is a lot of latex allergy, but a lot of times it's cutaneous. They don't start wheezing and pass out. That can happen. I had a student in my class once that had that level of allergy. I mean, things like the carpet has latex in it. To people with significant latex allergies. All right. So, what did your patient tell you? What symptoms are you looking for? They're like something's wrong. Something's not right. The book says a feeling of impending doom, but rarely does my patient say, I have a feeling of impending doom. Usually they say something like, something's wrong, I don't feel right. I feel like something's wrong. And so it's that, believe your patient when they say stuff like that. Then they start itching within minutes of exposure, the edema starts, the wheezing, all of that will start right away. Followed closely, we're talking within minutes. The blood pressure drops, they get the tachycardia, weakened pulse, dilated pupils, dyspnea, difficulty breathing, right? Quickly, all right. So just another pictorial thing. Hives, swelling, itching on their skin, coughing, wheezing, shortness of breath, tightness, trouble swallowing. In respiratory allergies like hay fever, sneezing, runny nose, itchy nose, they may experience some of that too, but they're too busy going, to care about their runny nose. Nausea, stomach pain, diarrhea, dizziness, pallor, weak pulse, and then anxiety, feeling of doing something wrong. And if you're female, uterine cramps. I've never known a man to complain of that. All right. So what do? Well, you guys learned EpiPen. Epi is fast-acting, vasoconstrictive, bronchodilating. It's an awesome, cool drug for this because it's going to work fast. Short half-life. Might have to give it again because the allergen might have a longer half-life, right? So you can repeat your EpiPen, right?
Yes.
Remember that?
Yes.
That's not new. Okay.
That's why they give it to them too.
Caribbean packs of 2. Right. If you have, you give one, call the ambulance. You can give another one while you're waiting. You shouldn't wait till after you've given 2 to call the ambulance, right? Because ambulance response time can vary greatly. All right. So, but H1 and H2 blockers, there are docs will say if you have a tag in it, go ahead and take it. At least it's going to block antihistamine. If you have antihistamines, go ahead and take it. We generally try not to put a lot in their mouth and their stomach because of the diarrhea and the absorption. It's got to take a while to work, right? Epinephrine is going to tighten up the junctions to decrease the edema and help decrease the bronchospasm, as well as constrict the blood vessels and bring your blood pressure up. So it's got double duty. It's going to fix your airway and your blood pressure. We love it for that reason. And then if you're in the hospital, we're going to start an IV because we have to support that blood pressure while we're getting that, whatever the allergen out of your system. Make sure they're stable. Desensitization. That's allergy shots. If you are significantly allergic to bee stings or certain pollens and things and they're causing bad anaphylactic responses, we can do allergy sensitization through allergy shots where we give you a little bit and we watch you for 30 minutes and we do that every week or so. We give you a little bit and a little bit more to sensitize you so your body's used to it and no longer recognizes it as a foreign body. Desensitization therapy, that's what that is, allergy shots. Okay, so at home, use an EpiPen, should have it near you. You don't want it across the house. You're working in the kitchen, you got a wasp sting, your EpiPen's 10 rooms and 1 floor away, and you're itching and wheezing and bronchoconstricted. That's never a good thing, right? You can use it twice. It should be IM straight into the thigh. We say IM or sub-Q because some people are really thick and the needle does go sub-Q. It's still okay. We're given the EpiPen. Use it the first sign. Don't wait until you've passed out. Use it the first sign. Half-life is 10 to 20 minutes, so you might have to repeat it. Call the doc or the ambulance after the first use. So, our treatment as Nancy Nurse or Ned Nurse is stop the offending agent. If they were getting Anseth IV, turn it off. Don't give any more. Don't say, well, when that bag's finished, I'll take it down. Right? Turn it off. We're going to ensure their airway's patent. We have airway cards. We probably will need to call a rapid response team because they're having true anaphylaxis. We need to address that. What position do you keep patients in to keep their airway open? Yeah, sniffing. You say sniffing? Sniffing. Head back. Keep the airway, keep the tongue out of the way. Sniffing position. We probably want their head up until their blood pressure gets so low, then they have to go head down, right? Because until your blood pressure is 60/40, you can do this. When your blood pressure and your pulse pressures are really bad, you have to put your head down. We still can keep your airway open, right? We still want this. What if the patient had a C-spine injury? What do we do with their airway then? A C collar is nice, but how do I open an airway on a C? Jaw thrust. Thank you, whoever my paramedic with their good response was. Absolutely. Students always forget the jaw thrust. Are you a paramedic? You work in ER? Yes. That was a yes. Okay. But it's a jaw thrust. Yeah, people forget that, and it's important. All right. So we're going to apply oxygen. Now, what kind of oxygen? Am I going to put on a 2-liter nasal cannula? No, they've got shock. Their blood count is low. They're tachycardic. Their blood pressure is low. Get a non-rebreather mask and ratchet that thing up to 100%. Load up their hemoglobin with oxygen. You make sure you've got a patent IV, high sodium chloride. Keep their head up slightly. Administer diphenhydramine. Benadryl. It's an antihistamine. Affects all 3 receptors of antihistamines. Will block the mast cells. That's what it does. It blocks mast cells. And then we're going to have antihistamine and epinephrine. We're going to repeat it again if we need to. We can nebulize aerosol treatments. Albuterol. Albuterol is a bronchodilator. What's it going to do to your pulse? Elevate it. You're already tachycardic, right? So you're watching them, though. There's some things that happen when your patients get too tachycardic. Tachycardia is, in the presence of shock, it's compensatory. From a med, it's a side effect, right? So it's not like I'm worrying about them with a heart rate of 120 because I have 2 things that are causing it. But when you talk about perfusion, the heart beats, it pushes blood out to the aorta. You have coronary arteries right at the opening to the aorta. And blood leaves the left ventricle, the valve shut, right? So it can't backflow. The aortic valve shuts. When the aortic valve shuts, it opens up the opening to the coronary arteries, and blood enters the coronary arteries and oxygenates the heart. But that's during diastole, right? The heart's at rest and the valves are shut. Now the heart contracts, it opens the valve, that valve covers the opening of the coronary arteries, blood squirts out. When the heart rests again, it opens that opening up. So now my heart's going 60 to 80, my blood is getting to my coronary arteries. It's happy, right? My tachycardia goes up to 120, 130, 140, 150, 160. How much diastole do I have? So much less. So how the oxygen perfusion to the surface of the heart? Less oxygen perfusion to the heart muscle. But what at this moment of going 150 beats a minute does your heart need? More oxygen. It has to make more ATP, right? So at this point, we do have to watch our patients for angina and heart attacks, right? So we just have to be cautious. It doesn't mean we don't do it. We do give albuterol to bronchodilate. We always give we want that. But it's cautious, right? Just awareness. Nurses have to be prepared. Corticosteroids, what are they going to do? They're anti-inflammatory. This is an inflammatory process. It's causing the whole thing. It's going to stop it. Then we can give volume expanders, things that expand the amount of fluid in your blood by increasing colloidal pressure. We talked about one of those this morning. Something that would increase colloidal pressure in your blood. Albumin. You can give albumin or Exastarch or Hetastarch. Or there's several of them on the market that are all volume expanders that pull fluid in your bloodstream. Stay with your patient. Don't leave a patient who's bronchoconstricting, wheezing, tachycardic, and in shock. Stay with them, being prepared to do life-saving intervention while you send somebody else to do all the other stuff, because you're actually calling the rapid response team, and they're coming to your rescue, right? And teach the patient to wear a medical ID bracelet and carry their EpiPen when they go home. All right, so epi is an adrenergic agonist. So the symptoms are restlessness, shakiness, nervousness, arrhythmias, because it's going to make them tachycardic. That's what it does. The shock made them tachycardic. The epi makes them tachycardic. The albuterol makes them tachycardic. Are we going to have tachycardia? Most likely. And it's going to bring their blood pressure up. So that's a good thing. All of those are good things. Diphenhydramines, the antihistamine, it's going to make you dizzy, drowsy, and dry, right? It's going to make everything dizzy, drowsy, and dry. Hypotension, urinary retention, dry mouth. Things like after you take an antihistamine, you've got a little hay fever. And then corticosteroids is going to block the inflammation. We know it causes edema and mood swings and sleeplessness and blah, blah, blah. And vasopressors, drugs that constrict the blood vessels. Norepinephrine. Very common drug we give for that. Vasopressin. Another very common drug we give for that. Right? So it's a combination of things. You can see what their side effects are. Again, this is a life-threatening illness. The person's going to die from a lack of oxygen and a lack of blood perfusion if we don't do something. So they're going to lose consciousness, their airway's going to close, they're going to go into shock, they're going to die. So that's why we do EpiPen, oxygen, IV, airway, blah, 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 right? Perfect. This just shows you the pathway from anaphylaxis or sepsis. Both of them were distributive shocks, right? So they have similar sequelae. Your cardiac output drops, your heart rate goes up, your stroke volume goes down, preload and afterload go down, your peripheral vascular resistance drops, and everything's changing, okay? And the patient's going into shock, and they're dying. All happy. So this is just a public safety poster that's up in a lot of workplaces. You know, obviously there's loads of companies who sell these. It's got a lot of cool stuff that's kind of summarizes this whole lecture. It is 12:30. Let us come back at 1:15, and we'll do TV. Give you 45 minutes because you guys are pretty bored.